Hello, this is David Greene, founder and CEO of R3 Medical Training. Today we're going to talk about the basics of PRP therapy for providers, basically what as a provider you should know. Now here's what we're going to talk about: what's in it, what it is, what's in it, single versus double spin. There is some controversy about what's the gold standard, and then some of the indications and research. I'm not going to delve into the history of PRP. But before it got popular in musculoskeletal, which is predominantly what we're talking about, it's been used heavily and still is for wound healing, dentistry, cardiac surgery, things like that. But we're going to focus on the musculoskeletal. So the definition of PRP is it is an autologous blood sample that has a platelet concentration above that contained in a normal baseline blood plasma. And platelets contain over 30 bioactive proteins, many of which have a fundamental role in tissue healing. Everybody thinks about them as being so great for clotting, and they are, but the fact is they do so much more. So when you're talking about clinical PRP, when you look at normal blood, there are 200,000 platelets per microliter on average. Studies that have been done looking at what it takes for bone and soft tissue enhancement with healing is increasing that to 1 million platelets per microliter. And when you do the math, that's 1 billion platelets per milliliter. So when you're talking about clinical PRP, in a typical 5 milliliter treatment, that would be 5 billion platelets. So we're not going to go through all this, but just suffice it, there's about 7 to some people say 12 growth factors in PRP. And here's the predominant ones: platelet-derived growth factor, TGF, beta, VEGF, epidermal, fibroblast, connective tissue growth factor, and insulin-like growth factor. And this is predominantly where the bioactive effects of PRP come from, is these particular growth factors. So activating PRP is a fairly complicated process, but we'll start at the top here. The activation causes granules in the platelet to fuse to the cell membrane. That's called degranulation. Then it activates the proteins and growth factors, which get secreted, and most of this takes place within 1 hour. Okay, it's not really lengthy delay. This leads to some intracellular activation in the recipient, which creates some gene sequencing, which does all the things that we love about PRP, directing cellular proliferation, collagen synthesis, etc., which provokes tissue repair and regeneration. Okay, so when you prepare PRP, the blood comes from the patient, and you collect the blood just like you normally would at a lab, and then you put it into the tube or the kit. There are so many of them out there. We're going to talk about M-Site. But when you do the first spin, and the first spin is in a centrifuge, and it could be, for M-Site it's only 1 minute. For some systems it's like 5 or 10 minutes, but it's got to be very fast, usually between 3 to 4,000 RPMs. And what you'll find is that the blood separates. So the red blood cells are at the bottom. They're the heaviest, so they go to the bottom. We really don't want these. Studies have shown various deleterious effects of RBCs, such as blood in the joints leading to degenerative changes. Studies showing synovial fluid that was treated with RBCs results in cell death. So really, we don't want this part much at all. Okay, so that gets discarded. The top layer is mostly just plasma. We'll talk about plasma in a minute. And then the middle part is called the Buffy Coat, which I think The Buffy Coat is rich in white blood cells and platelets. And actually, this arrow should be up here. And here are the 5 major types of white blood cells. Okay, there's neutrophils, lymphocytes, eosinophils, monocytes, and basophils. And it's a very good idea to elucidate that there are different types of white blood cells, because some we want and some we don't. So here's another illustration showing the top layer, which is plasma, and that has water in it, proteins, as well as various nutrients with amino acids and sugars and hormones. So it's not a useless layer. can be very helpful, and we do want a significant amount of that. Now, if you're just going to do a single spin, then you would use this middle layer. Once again, the arrow should be here. It's called the Buffy Coat, and it does have a lot of leukocytes, which are white blood cells, and platelets. So if you just do a single spin and use this middle layer, the Buffy Coat, that would be a leukocyte-rich PRP. Okay. Now here's the process, as we talked about: collecting the blood, putting it in the tube or the kit, centrifuging it in the machine, and then if you're just going to do a single spin, aspirating out the Buffy Coat, trying to minimize the amount of red blood cells you get, and having some plasma in there is just fine. Alright, second spin. You would take the top layer, which is mostly plasma, and the middle layer, the Buffy Coat, and transfer that out. Okay. What you don't want, as I mentioned, is the red blood cells, the bottom layer. Those you want discarded. So most kits you aspirate until you get a tinge of pink, which is where the red blood cell layer starts, and then you stop. Okay. When you do a second spin, what you're going to end up with is a large top layer, which is mostly platelet poor plasma. Okay. And then the platelets are going to spin to the bottom, and that's where your platelet rich plasma is. All right, so PPP and PRP. Okay. Now, some of the questions that we have to date still, after a lot of research, is should you activate it or not? What's the optimal type of PRP to use? Should you use a leukocyte-rich, with just one spin, or do a second spin where you have a leukocyte-poor? Or do you use PRP by itself or along with stem cells and or exosomes? So we'll go through some of the answers to this moving forward, but yeah, there's no gold standard. So here's an example of why our company recommends MSite, and here's why. This study looked at a comparison of a lot of different systems, and leukocyte poor would be those that have a second spin capability, and then the comparison, MSite showed really good concentrated volume produced, and as well as could it produce PPP, what's the increase in platelets from baseline, and here you get clinical grade of 5 times, and what's the capture efficiency. So the higher the increase in platelets, the better. To a point, if you get really up to like 10 or 11 or 12, you're probably going a little too far with it, but you definitely want a clinical grade. So when you look at the MSite system, it offers upwards of 9 billion platelets in a 7 milliliter sample. Really good control of the neutrophils. They are the most abundant leukocyte, and they show up very quickly at the injury site. Normally they are cleared quickly by the macrophages, but if not, they die and release all their pro-inflammatory contents. So if you have very high neutrophil counts, which is what you have after a single spin, then you can actually create a bigger problem, for the first week or two with just that, as opposed to having the second spin where you keep the monocytes and but take out a lot of the neutrophils. Now, does age affect PRP quality? This is something that I used to think did, and that people who are of advancing age shouldn't have PRP. Maybe should have something else, like just stick with exosomes or stem cells. But this study in 2004 showed no significant changes in platelet concentration or growth factors in relation to age or gender. So what that says to me is it doesn't matter if somebody's 70 versus 50. You still have the concentrations necessary, produce clinical grade PRP. So we're going to go through some indications and what the research shows, whether it's for soft tissue problems like an Achilles tendonitis, plantar fasciitis, rotator cuff tendonitis, elbow and greater trochanteric bursitis tendonitis, and then joint arthritis as well, and along with the spine. All right, so for Achilles tendonitis, This study looked at a PRP injection for chronic Achilles tendinopathy. It was out of JAMA. It was over 50 patients, aging is 18 to 70. This was chronic mid-portion Achilles tendinopathy versus a saline injection, and it didn't work. It did not result in greater improvement in pain and activity, which would lend the argument against PRP for this type of Achilles tendinopathy. Now, for plantar fasciitis, this was out of the Malaysian Orthopedic Journal just last year, and it showed that PRP injections were extremely helpful for plantar fasciitis. For instance, if you look at the visual analog scale table here, before treatment it was around 7. 6 weeks out, the steroids actually were doing better. But look what happens when you go to 3 months and to 6 months. The PRP group gets better and better. It just keeps on getting better. And this was statistically significant. Now, for rotator cuff issues, this study was a meta-analysis. What that means is it pulls together several studies, in this case 5, which accumulated over 200 patients in the Journal of Arthroscopy last year. And all these meta-analyses include studies that are done differently, so they include the same limitations with limited available evidence using PRP for non-operative treatment of chronic rotator cuff disease. It just may not be beneficial. So for rotator cuff issues, what we recommend from these studies and others is basically PRP plus a stem cell biologic or exosome. So let's look at jumper's knee. There's 2 studies out there that showed really good results. This one, Liddell et al., showed 81% of patients returned to pre-symptom levels of activity. And this one showed better pain relief and function with 2 injections versus 1. So both these studies used a leukocyte-rich preparation, meaning just 1 spin. And PRP does appear to be a viable treatment option for chronic jumper's knee, and probably a leukocyte-rich preparation. And if you go by the Zaney and all data, you probably should do more than 1, separated out by 3 to 6 weeks. Tennis elbow has been actually very well studied. This was a meta-analysis that was done fairly recently over the last year, and it did show that PRP was better at reducing pain in the short and the long term versus steroid, and the effects lasted up to 2 years, which is pretty much what the follow-up was for the study. Additionally, versus steroid, you don't have that subcutaneous fat atrophy, which is always unpleasing cosmetically and a little alarming to patients. And another study showed that leukocyte-rich yielded better long-term results than lidocaine or dry needling. So once again, probably just 1 spin for treatment of tennis elbow. All right, so partial tears of elbow ligaments. In the major leagues, this is the ulnar collateral ligament, right? And then a lot of times if you have a significant tear in that or a full tear, pitcher goes on to need Tommy John surgery. However, it may not be necessary with PRP. So Podesta and all followed the progress of 34 throwing athletes who had partial thickness tears, who only had a single PRP injection, and 30 of them were able to return to the same level of play or higher within a few months. So as opposed to being out for a whole year with a Tommy John surgery, potentially you can avoid it. Here's an example of Shohei Ohtani. He is remarkable. He plays for the Angels, and he's able to pitch, and he plays the outfield, and hit home runs. So, nobody exists like him in the major leagues. So he's just one example of somebody who did well, at least for a while, with PRP therapy. Several pitchers, New York Yankees right-hander Masahiro Tanaka, this guy from Boston Red Sox, Chris Sale, had PRP therapy injection as conservative treatment and continued to pitch. Ohtani, unfortunately, he did well initially. He was able to finish the season, I believe, in 2017. And then he did end up needing surgery after the season was over. But it did allow him to at least finish the season before he needed the surgery. All right, Trochanteric bursitis. This is pretty exciting. PRP versus surgery. They both did well in these meta-analysis of 10 studies, over 200 patients. So they both did well. PRP therapies did really well, equivalent to surgery, but they didn't have all the complication rates, right? Like re-tears or blood clots or wound issues, snapping hip. So it's better, obviously, to try PRP therapy first. Here's a compilation of arthritis studies. There's a lot of them out there. So in this table, it's actually very helpful. You can see that all these knee studies, there's 8 of them. 7 out of 8 showed positive results with PRP therapy. So when you look, and then in the hip, 2 out of 4 were positive. And when you look at what the preparation that was used in most of these studies, that was positive outcome, it was leukocyte poor. That means that the blood was put through a second spin, and you end up with a low level of neutrophils, but you maintain the monocytes. So it really does starting to show us a clear path here that leukocyte poor PRP is better in hips and knees, and you can get a very satisfactory outcome. So here's one that looked at 14 different studies and over 1,400 patients. They showed that intra-articular PRP injections probably are more effective in the treatment of knee arthritis compared with saline, placebo, hyaluronic acid, ozone, corticosteroids. And this was upwards of a year of follow-up. Should you do one injection or multiple? This study looked at that last year. 95 patients were looked at for only 4 months. But they did find that the effectiveness of PRP did increase after multiple injections 3 weeks apart. For the spine, this is a study in 2019 which showed that a subset of patients demonstrated clinically significant improvements in pain and function from 5 to 9 years post-injection of PRP into the disc, which is remarkable to have that long of a follow-up with excellent results. For Fassett Arthritis, this is a Russian study that looked at almost 50 patients for a year and a half, and they found that there was a persistent, significant reduction of pain symptoms and increase in function in the early and late post-procedure periods with low risks of complications. And looking at TMJ, this was a meta-analysis looking at 6 different studies and showed that 4 out of 6 showed superiority with PRP for TMJ with range of motion and pain upwards of a year. So that is remarkable. You know, TMJ is very, very frustrating, and this is fantastic to be able to have that kind of an option. So in conclusion, PRP is very low risk. Typically patients may have increased pain for a few days after the procedure due to the inflammation that it creates. Studies that have looked at the differences in pain versus a single or a double spin really don't show much of a difference. People think the second spin is going to reduce those neutrophils and decrease pain, but that's really in theory. We do have a lot of unanswered questions. What is the optimal dose? We think it's 5 to 7 times normal platelet concentration, where you can get 1 billion platelets per milliliter. That's what we think is best. Should you activate or not? It's not hard to activate, using calcium citrate or something like that, but we do know that once you inject PRP, it gets activated anyway underneath the skin with all the bioactivity. So, do you need to activate? A lot of people say no, but others are adamant about it. Do you use leukocyte rich or leukocyte poor? Well, we just looked at some studies where leukocyte rich showed better results in the soft tissue problems, whereas leukocyte poor was better in the joints. So that's what most people will do, but there is no gold standard right now. We have a lot of positive studies out there, and PRP therapy is a great option. Most of our clinics will use stem cells and or exosomes along with PRP. Why? Well, there's in theory that some of those activate the PRP more and vice versa. There's a lot of data that we've seen as well as anecdotal showing that it does better for things like, sexual wellness and hair restoration, and for joint issues, gives longer lasting results, and so on and so forth. So that's what we've seen, and that's why most providers are adding the two. A lot of them inject them separately, but the results have been fantastic. So R3 Medical is partnered with R3 Stem Cell for providers nationwide with its partnership program. We have a large network, over 40 centers that we help with for patient acquisition with marketing, and this includes online as well as seminar marketing. We actually come in and do the seminars, so practices do not have to worry about it. We offer an incredible amount of sales support. What's the use of getting a lot of patients in if you're having trouble converting them? We have first-rate products at significant savings, usually 30% lower than what the lab will charge for them. We have over 7 IRB-approved protocols. We do have extensive provider training, and that's either online or in person, where you can see, do, and have procedures, which is remarkable for a provider to be able to empathize and with his or her patients. So it really is an all-in-one regenerative medicine program, which will help you to acquire new patients, convert them for procedures, and then use our protocols. So call us today at 844-GET-STEM. Be happy to talk with you about your practice and how we can help. And the other place to see more information is just go to r3stemcell.com, and you click on for providers, and you'll see all the information about the program, and then give us a call. Thank you so much. Hope you enjoyed this.